Bismillahirrahmanirrahim. Welcome again in this work which aimed to upgrade your knowledge with latest published guideline and our talk will be about diagnosis, evaluation and management of ascites in patients with cirrhosis 2021 practice guidance by the American Association for the Study of Liver Disease. This work dedicated to the soul of my father. The SLD practice guidelines continue chose to perform a guidance on this topic because a sufficient number of randomized controlled trials weren't available to support meaningful systemic review and meta-analysis. Burden of cirrhotic ascites. Hepatic decompensation defined by ascites, hepatic encephalopathy, and portal hypertensive gastrointestinal bleeding is an important landmark in the natural history of cirrhosis. Ascites is commonly the first decompensation defining event, with 5 to 10% of patients with compensated cirrhosis developing ascites per year. The development of ascites is associated with a reduction in 5-year survival from 80 to 30%. Patients with ascites being prone to additional complications such as bacterial infections, electrolyte abnormalities, hepatorenal syndrome, and nutritional imbalances consequently furthers clinical decline. Patients with cirrhosis who develop clinically significant ascites and related complications should be considered for referral for liver transplantation. Pathogenesis of ascites and related complications of cirrhosis. Cirrhosis causing splanchnic vasodilatation, and the central event of most complications consists of effective arterial underfilling. This leads to activation of vasoconstrictors as renin-angiotensin and antidiuretic factors as arginine vasopressin. This causes sodium retention, plasma volume expansion, and ends with ascites formation. It leads also to increased aquaporin 2 expression, which is causing teleogenal hyponatremia. And it leads also to renal hypoperfusion and ends with hepatorenal syndrome. Cirrhosis causing portal hypertension, which causes increasing sinusoidal pressure and increasing lymph formation and end with ascites formation. Cirrhosis also is a cause for bacterial translocation, so spontaneous infections and systemic inflammation, which end with hepatorenal syndrome. Diagnostic evaluation of a patient with ascites. The initial evaluation of ascites should include history, physical examination, abdominal Doppler ultrasound, laboratory assessment of liver and renal function, serum and urinary electrolytes, and diagnostic paracentesis. In evaluating the etiology of ascites, the serum albumin ascites gradient is calculated by subtracting the acidic flow albumin from the serum albumin in simultaneously obtained samples. So the guidance statements: a diagnostic paracentesis should be performed in all patients with new onset ascites that is accessible for sampling. And the initial laboratory investigation of acidic fluid should include acidic fluid neutrophil count, acidic fluid total protein, acidic fluid albumin, and serum albumin to calculate the serum ascites albumin gradient. In this sample graph, we will show a diagnostic approach to nuanced ascites. Starting with diagnostic paracentesis, and we have to evaluate the serum ascites albumin gradient if it's less than 1.1 gram per deciliter or more than 1.1 gram per deciliter. If it is less than 1.1 gram per deciliter, this means it is mostly peritoneal disease. So you are going further for this evaluation. Abdominal imaging, acid-fast bacterium, and adenosine deaminase can be evaluated, and we may need laparoscopy with peritoneal biopsy. If the serum ascites albumin gradient is more than 1.1 gram per deciliter, so we have to evaluate for the acidic fluid protein. If it's high, more than 2.5 gram per deciliter, so the cause mostly is post-sinusoidal, and so hepatic venous Doppler and echocardiography may be the next step. And if not diagnosis reached, we may need hepatic venogram or hepatic venous pressure gradient and a transjugular liver biopsy. If the serum ascites albumin gradient was more than 1.1 gram per deciliter and the acidic fluid protein is less than 2.5 gram per deciliter, so the cause mostly is cirrhosis. So imaging and elastography and this may need further evaluation with the hepatic venogram and the hepatic venous pressure gradient or transjugular liver biopsy. In this table, we will show a guidance to diagnostic paracentesis in patients with cirrhosis, and we will show what test to use and the indications in first episode of ascites and recurrent ascites in both inpatient and outpatient condition. Starting with serum acetic albumin gradient, which is indicated in the first episode of ascites in both inpatient and outpatient, and it's not indicated in recurrent ascites. The polymorphonuclear leukocytic count in the ascites is indicated in all cases with ascites, either first episode of ascites or recurrent, inpatient or outpatient, to exclude the infection. Culture is only indicated in cases of inpatient in both first episode or recurrent ascites, and protein concentration is needed at the first episode of ascites, and in recurrent ascites it's only needed if we are intending to start a primary prophylaxis of SPP in both inpatient and outpatient, and inpatient cases with recurrent ascites we can use it for a secondary bacterial peritonitis is suspected. Glucose concentration, it is not used in outpatient condition at the first episode of ascites or recurrent ascites, but it is used in inpatient conditions, and the main use to when is a bacterial peritonitis is suspected. Lactate dehydrogenase is only used in patients' condition only when a secondary bacterial peritonitis is suspected, and it is used in both first episode or recurrent ascites, and it is not used at outpatient condition. Cytology, it is used at first episode of ascites inpatient only when secondary bacterial peritonitis is suspected, and in outpatient setting it is only when causes of ascites other than cirrhosis are suspected. We don't use cytology in the cases of recurrent ascites. Amylase concentration also not used in the recurrent ascites, and it is used only in patient condition at the first episode of ascites when a pancreatic origin of peritonitis is suspected, and in the case of outpatient condition we only use it when other causes of ascites other than cirrhosis are suspected. Classification of ascites. In patients with cirrhosis, ascites can be graded according to the amount of fluid accumulated in the abdominal cavity and classified according to the response to treatment. Starting with grading of ascites, Grade 1, it is mild ascites, which are only detected by ultrasound. Grade 2, it is moderate ascites with moderate symmetric distension of the abdomen. And Grade 3, it is large or gross ascites, which marked distension of the abdomen. And according to the response to treatment, it can be classified to responsive ascites, which are ascites that can be fully mobilized or limited to grade 1 with diuretics therapy associated or not to moderate dietary sodium restriction, and recurrent ascites, that ascites that recurs on at least 3 occasions within 12 months period despite dietary sodium restriction and adequate diuretic dosage, and refractory ascites, which ascites that can't be mobilized or early recurrency of which after large volume paracentesis can't be satisfactorily prevented by medical therapy. In the plan of treatment, we have to mention that Grade 1 ascites, no treatment is recommended for it as there is no evidence that it improves patient outcome. And response to therapy and outcome in patients with grade 2 or 3 ascites depends on several factors such as underlying cause of cirrhosis, feasibility and the effectiveness of therapy to alter the natural course of cirrhosis, presence of superimposed complications such as renal failure, hyponatremia, spontaneous bacterial peritonitis, and adherence to the patient to dietary sodium restriction and diuretics. Treatment of cirrhotic ascites. Starting with dietary sodium restriction. Moderate dietary sodium restriction, 2 gram or 90 millimole per day, should be prescribed to achieve a negative sodium balance and a net fluid loss. Patient education for sodium restriction is essential to maximize adherence while avoiding malnutrition and sarcopenia. A formal consultation with a dietitian should be considered. And advice on content of prepared meals and avoid adding salt to cooked meals. In this, we can show a simple 10-step patient instruction of low sodium diet plan. Firstly, we can inform our patient to eat less processed food and inform them about the difference between the real food versus the processed food. and eating more fresh products, choose proper protein, and more home-cooked meals. The importance of reading labels as it shows the sodium content, and we have to learn our patient how to get creative with seasoning to make the food more palatable and remove the salted sugar from the table and avoiding the canned food. It is very important as it is a hidden source of salt in the diet. Fluid restriction. Fluid restrictions in patients with cirrhosis and refractory ascites is difficult to enforce and is often impractical. So patients' daily urine output is usually less than 1 liter, making it virtually impossible to achieve a negative fluid balance by restricting fluid intake to less than the urine output. The serum sodium concentration at which fluid restriction should be instituted hasn't been well defined, but it is recommended when serum sodium is less than 125 millimole per liter or its onset is rapid. So the guidance statement, fluid restriction, it is not indicated unless hyponatremia is present. Diuretic therapy. In most patients with cirrhosis presenting with ascites, dietary sodium restriction alone is insufficient and the diuretic therapy is necessary. But we have to guide our therapy through assessing the efficacy of diuretics and preventing their adverse effects. We have to know that the peritoneal membrane's ability to reabsorb ascites from the abdominal cavity is limited to approximately 500 ml per day. This reflected the body weight. Daily monitoring, preferably at the same time of the day, and in patients without peripheral edema, weight loss exceeding 0.5 kg per day may result in plasma volume contraction, predisposing the patient to renal failure and hyponatremia. While in those with edema, weight loss up to 1 kg per day may be tolerated. Laboratory monitoring is very important as serum electrolyte concentration, particularly during the first week of the treatment. We also can guide our therapy by 24-hour urinary sodium excretion, which differentiate between insufficient diuretic dose and dietary indiscretion. If the sodium excretion lower than the intake, like 80 millimole per day, this means this is insufficient diuretic dose. And if there is persistent ascites despite adequate urinary sodium excretion, this indicates a patient not restricted to the diet regimen. When a 24-hour urinary collection is not feasible, we can use the sodium-potassium ratio. A random spot urinary sodium concentration that is greater than the potassium concentration correlates with the 24-hour urinary sodium excretion. So the spot urinary sodium where potassium ratio is more than 1, this means that the patient is losing fluid weight. If the sodium to potassium ratio is less than 1, this means it's insufficient diuretic dose. And if it's more than 1 and no weight loss, this means that patient not restricted to the diet regimen. The diuretic therapy used aldosterone antagonist and loop diuretics is the mainstay of diuretic treatment of cirrhotic ascites. Two studies addressing the best way to use those diuretics showed for the first episode of ascites, the treatment with aldosterone antagonist alone generated adequate response with few side effects, whereas those with long-standing ascites responded better to a combined diuretic treatment. Doses. Spironolactone dose we can initially start with 100 mg per day, which can be progressively increased up to 400 mg per day. We have to know that spironolactone and its active metabolites have a long half-life. The full effect of a dose change may not be seen up to 3 days. When the dose is increased, it should be done cautiously and in a stepwise fashion with an interval of at least 72 hours. Furosemide initial dose is 40 mg per day and may be progressively increased according to the response and tolerability towards 160 mg per day. We have to mention that loop diuretics have a sigmoidal dose response curve, which means that once the ceiling dose is reached, further increase in doses won't increase renal sodium excretion. For patients with liver cirrhosis, the ceiling dose is reduced compared with healthy controls. Patients with chronic kidney disease in general are treated with higher doses of loop diuretics and lower doses of aldosterone antagonists. And the guidance statement, after ascites is adequately mobilized, attempts should be made to taper the diuretics to the lowest dose necessary to maintain minimal or no ascites to prevent the development of adverse effects. So, what are adverse effects of diuretic agents? Firstly, acute kidney injury with a rise of at least 0.3 mg per deciliter in 48 hours, and it is more with loop diuretics. Also, hyponatremia and hypokalemia more with loop diuretics, while hyperkalemia it is more with aldosterone antagonist, and especially if concomitant with renal impairment. Hepatic encephalopathy is more common with other diuretic-induced side effects as hyponatremia and reduction of extracellular volume, and gynecomastia, which more with spironolactone and less with eplerenone and amiloride. While muscle cramps is very important as it can lead to impairment of quality of life and mobility. And so the guidance statement for severe muscle cramps, we can use human albumin solution 20 to 40 gram per week or baclofen administration 10 mg per day with increasing of 10 mg per day up to 30 mg per day can be considered in cases of severe muscle cramps. Other drugs such as orphandrin and mesocarpamol have been proposed for muscle cramps in patients with cirrhosis. And finally, quinidine at a dose of 400 mg per day for 4 weeks in patients with cirrhosis was more effective than placebo against painful muscle cramps. However, toxicities such as diarrhea in about one-third of cases requiring treatment withdrawal may limit its use. Treatment of grade 3 ascites. For patients presenting with tense ascites, a large volume paracensis combined with hyperoxatic human albumin is the initial treatment of choice even in the presence of hyponatremia. Patients with massive peripheral edema may require a second paracensis shortly after the first because a rapid shift of fluid may occur from interstitial tissue to the abdominal cavity. After large volume paracensis and a significant reduction in the intra-abdominal pressure, diuretic can be instituted, which may eliminate or reduce the frequency of paracensis. So the guidance statements, large volume paracensis is the first-line treatment of grade 3 ascites. After paracensis, sodium restriction and diuretics should be started, and referral for liver transplantation evaluation should be considered in all patients with grade 2 or 3 ascites. We have to speak about the general medical management of patients with cirrhosis and ascites. Given the hemodynamic abnormalities in patients with cirrhosis and ascites, medications that may further reduce the effective arterial volume and renal perfusion should be avoided, and all potential nephrotoxins should be avoided in patients with cirrhosis and ascites. So the guidance statements, non-steroidal anti-inflammatory drugs, angiotensin-converting enzyme inhibitors, and angiotensin receptor blockers should be avoided in patients with cirrhosis and ascites. Also, aminoglycosides should be avoided whenever possible in the treatment of bacterial infection. In patients with cirrhosis and ascites, the use of intravenous contrast media it is not contraindicated. However, cautions needed to be exercised in patients with impaired renal function. Long-term albumin administration to patients with decompensated cirrhosis. An open-label randomized trial, the ANSWER study, on 431 patients with diuretic-responsive ascites were randomized to either standard medical treatment or standard medical treatment plus 40 grams of albumin twice a week for the initial 2 weeks and then 40 grams once a week for 18 months. This shows a significant better overall survival was seen in patients receiving albumin with a 38% reduction in mortality that's shown in the Kaplan-Meier curve that's shown at the right side of the screen. While on another randomized placebo-controlled trial in MATCH study, A 173 patient with ascites listed for liver transplantation were randomized to receive standard medical treatment plus 40 grams of albumin every 15 days and an alpha-1 receptor agonist midodrine 15 to 30 mg per day depending on the response, or standard medical treatment plus placebo. And this shows that despite some improvement in the parameters reflecting improved effective plasma volume, no difference was observed in the complication rate or death during 12 months. So the guidance statement: for patients with cirrhosis and diuretic responsive ascites, controversial data suggests the potential benefit of long-term infusion of human albumin solution. At present, no recommendation can be made for its use in routine clinical practice. Now we will speak about refractory ascites. Refractory ascites occurs in approximately 5 to 10% of all patients with cirrhosis and ascites, and it is associated with poor survival of 50% at 6 months, and it can be defined as ascites that can't be mobilized or occurs after large volume paraffin cells despite dietary sodium restriction and diuretic therapy. It can further divided into diuretic-resistant persistent ascites despite maximal dose of diuretics, and diuretic intractable, in which side effects of diuretics preclude the use of maximum dose. Recurrent ascites is defined as ascites that recurs at least 3 times within 1 year despite dietary sodium restriction and diuretic therapy, and it can be a forerunner to refractory ascites. This is a proposed algorithm for management of refractory ascites. Patient with grade 3 ascites while on diuretics. We will assess for diuretic response or complications. If there is no response to the maximum dose of diuretics, typically 160 mg furosemide or 400 mg spironolactone, or development of complications, we will check the urinary sodium measurement, and if there is maximum urinary sodium excretion, dietary history to assess for salt restriction, and if the patient compliant with sodium restriction, this means it is refractory ascites. We may have a trial with large volume paraffin cells with albumin to monitor the patient for post-paracentesis circulatory dysfunction and assessment of the liver dysfunction. If the patient with high MILD score, we can refer our patient for liver transplantation. If not severely liver dysfunction, we can have a trial with TIPS, and this may end with deterioration of liver dysfunction and so on liver transplantation. Treatment options for refractory ascites. Starting with medical treatment options for refractory ascites. Some patients with refractory ascites may reduce their ascites once they adhere to low sodium diet. So the guidance statement: continue dietary sodium restriction less than 2 grams per day is required in patients with refractory ascites to reduce the rate of ascites accumulation. Fluid restriction. Patient's daily urine output is usually less than 1 liter, making it virtually impossible to achieve a negative fluid balance by restricting fluid intake to less than the urine output. So fluid restriction is ineffective for the management of refractory ascites, but restricting fluid intake to less than 1 liter per day is recommended for treatment of hyponatremia less than 125 milliequivalent per liter. Chronic albumin infusion. In a cohort of 70 participants in patients with cirrhosis and refractory ascites, 45 of them whom received 20 grams of albumin twice weekly, there was a significant reduction in the 24-month hospital admission for complications of cirrhosis and mortality. But the guidance statements in this part: in the management of refractory ascites, there are insufficient data to recommend the long-term use of albumin infusion outside the setting of large volume paraffin cells. Large volume paraffin cells. It is defined as paraffin cells of more than 5 liters, and it has shown to be safe and effective. So the guidance statement: large volume paraffin cells is the first line of the treatment of refractory ascites. Albumin infusion is particularly important if more than 5 liters of ascites are removed to prevent the development of post-paracentesis circulatory dysfunction. And this is defined as reduction of effective arterial blood volume and clinically includes renal impairment, delusional hyponatremia, and hepatic encephalopathy or death. while smaller volume are not associated with significant hemodynamic changes and albumin infusion may not be required. In patients with hemodynamic instability, as systolic blood pressure less than 90 mm mercury, hyponatremia as serum sodium less than 130 mmol per liter, and the presence of acute kidney injury, albumin infusion should be strongly considered for paracensis of a smaller volume. So the guidance statement, albumin infusion at the time of large volume paracensis of more than 5 liters is recommended to mitigate the risk of post-paracentesis circulatory dysfunction. There is no limit for the amount of ascites that can be removed in a single session provided an appropriate amount of albumin is administered. While the guidance statement here, the risk for post-paracensis circulatory dysfunction may increase with more than 8 liters of fluid evacuated in one single session. Although there is no dose-response study on albumin used with large volume paracensis, the recommended dose of albumin replacement based on expert opinion is 6 to 8 grams for every liter of ascites removed. Large volume paracensis is a safe procedure even in the presence of coagulopathy. In a study that included patients with an INR more than 1.5 and platelet count less than 50, only 1% of patients experienced minimal cutaneous bleeding after large volume paracensis. Therefore, elevated prothrombin time or thrombocytopenia is not a contraindication for paracensis or an indication for transfusion of clotting factor. Possible exceptions may include patients with disseminated intravascular coagulation or uremia and thrombocytopenia. Desmopressin may be considered particularly if there is a history of prior bleeding. The third arm in the treatment of refractory ascites is transjugular intrahepatic portosystemic shunt, TIPS, and liver transplantation. TIPS insertion causing reduction of portal pressure, and this is as gradual return of the splanchnic volume to the systemic circulation through the TIPS and end with improving of the effective blood volume. But we have to know this. There is gradual separation of the activated neurohormonal vasoconstrictor systems over 4 to 6 months. So, clearance of ascites is not immediate post-TIPS and even post-liver transplantation, and patients should be maintained on a sodium-restricted diet until ascites is adequately controlled. Diuretic reduce the intravascular volume, which may slow the refilling of the effective arterial blood volume and counteract the volume refilling effect of TIPS insertion, so delay ascites clearance. But nearly 80% of patients with clear will clear their ascites with TIPS. Patients who fail to do so despite a widely patent TIPS at 12 months should be referred for liver transplantation. And the guidance statement, liver transplantation should be considered in patients with refractory ascites. Concerning TIPS in treatment of refractory ascites, patient selection and timing for TIPS is critical for successful outcome. TIPS in well-selected patients with refractory ascites has been shown to be better than repeated large volume paracensis in both the control of ascites and survival. Patients with high MALD score more than 18 are poor candidates, and certain risk factors like advanced age, cardiopulmonary insufficiency predispose patients to more complications. So the guidance statements: careful patient selection is the key to the success of TIPS in the management of refractory ascites. TIPS stents with a smaller diameter than conventional ones have been associated with lower incidence of post-TIPS hepatic encephalopathy without compromising the efficacy on ascites control. So the guidance statement, a small diameter coated stent of less than 10 mm is preferred to reduce the likelihood of post-TIPS complication, including hepatic encephalopathy. Doppler studies may miss TIPS stenosis, so venography should be considered in patients with persistent or recurrent ascites even if Doppler is reported unremarkable. So the guidance statement, if ascites recurs after initial clearance, a TIPS venogram should be considered and TIPS revision should be performed if stenosis is identified. Follow-up integration of the stent in a symptomatic patient with a covered stent probably has a little therapeutic impact. However, the guidance statement in patient received revision for TAPS dysfunction and with a prosthrombotic state, long-term periodic Doppler ultrasound surveillance should be considered. We have to mention that there is a controversy about non-selective beta blockers in patients with refractory ascites. Non-selective beta blockers are the standard of care for the prevention of arterial bleeding in patients with cirrhosis and portal hypertension. The window period hypothesis, suggesting that non-selective beta blockers were only used during a certain window of period and natural history of cirrhosis. Beyond that time, non-selective beta blocker use could be detrimental. A randomized controlled trial conducted in patients with compensated cirrhosis, the use of non-selective beta blocker was associated with a reduced incidence of ascites, suggesting that the use of non-selective beta blocker in the early stage of cirrhosis is beneficial. For now, only caution the use of non-selective beta blocker in patients with refractory ascites, especially in those with hemodynamic abnormalities as indicated by low systolic blood pressure less than 90 mm mercury, hyponatremia with serum sodium less than 130 mmol per liter, and serum creatinine more than 1.5 mg per deciliter. Non-selective beta blocker might be reintroduced if circulatory dysfunction improves with improvement of these parameters. So the guidance statement, based on the currently available data, non-selective beta blockers are not necessarily contraindicated in patients with refractory ascites. However, caution is recommended in patients with hypotension, hyponatremia, or acute kidney injury. And takeaway message, a diagnostic paracensis should be performed in all patients with new onset ascites that is accessible for sampling, in moderate sodium restriction, 2 gram or 90 millimole per day, and diuretic spironolactone with or without furosemide are the first-line treatment in patients with cirrhosis and grade 2 ascites. And the fluid restriction is not necessary for ascites management unless there is concomitant moderate or severe hyponatremia if the serum sodium less than 125 millimole per liter. Large volume paracensis is the first-line treatment of grade 3 ascites. After paracensis, sodium restriction and diuretics should be started, and referral for liver transplantation should be considered in patients with grade 2 or 3 or refractory ascites. Larger volume paracensis is the first line for the treatment of refractory ascites, and care for patient selection is the key to success of TAPS in the management of refractory ascites. And based on the currently available data, non-selective beta blockers are not necessarily contraindicated in the patient with refractory ascites. However, caution is recommended in the patient with hypotension, hyponatremia, or acute kidney injury. Thank you.